Okay, today we shall examine the abdomen of the patient. Abdomen, just like other any systematic examination, the examination of it consists of inspection, palpation, percussion, and auscultation. And as always in medicine, we have to take a permission from the patient and provide him or her with full privacy. I shall take a permission from the patient. السلام عليكم. شلونكم هذا اليوم؟ سمحنا اليوم نفحص بطنك إن شاء الله. Okay. Really, prior to the examination of the abdomen, we have to know how can we classify the abdomen into different regions. Really, we have two classification. The first one, which classify the abdomen into 9 regions, which is the most famous one and the most accurate one, and the second one, which divides the abdomen into 4 regions, just like this. I'll show it on this volunteer. Initial classification, we have 2 planes. The first one passing from the L1, transpyloric, we call it transpyloric, here, passing here, and the second one, horizontal plane, passing at the upper border of both iliac fossae, here, and 2 vertical planes, mid-clavicular into mid-inguinal region. So the resultant 9 regions are right hypochondrium, epigastrium, here, left hypochondrium, here is the umbilical region, right flank, left iliac fossa, right iliac fossa, and here is the suprapubic area. This is one of the classification. The second one, which divide the abdomen into 4 regions, really we have just 2 lines crossing the umbilicus in the following manner. So the resultant quadrant are the right upper, right lower, left upper, left lower quadrants. This is about the classification of the abdomen, and I shall now examine the abdomen. I'll start with the inspection of the abdomen, just like this. First of all, I have to stand at the end of the bed. Really, I'll see the pattern of the abdomen, contour of the abdomen, and texture of the abdomen. After that, I shall ask the patient to cough. This really test is to increase intra-abdominal pressure for the expansile cough impulse for any hernia. Then I'll kneel or sit at the side of the abdomen, also to look for these 3 parameters. As I said, the pattern of abdominal movement, texture of the abdomen, and contour of the abdomen, I shall talk about them now. Regarding the pattern of abdominal movement, if we have a focusing just like this on this part of the abdomen, we will see that the abdomen is gently rise with the inspiration and fall with the expiration. This is mainly abdominal movement, which is common in men, while in female it is mainly thoracic. This is regarding the pattern of abdominal movement. Other movement that should be noticed in the abdomen are the visible peristalsis. Visible peristalsis, one should look at the right hypochondrium. If there is any peristaltic movement that descend to the suprapubic area and ascend up, or from the right hypochondrium from the left hypochondrium into the right hypochondrium. The first one suggests gross gastric dilatation. The second one suggests just pyloric obstruction. Visible peristalsis may be a normal finding in elderly patient with lax abdominal muscle and thin abdomen. Other movement that should be noticed in the abdomen is any visible pulsation. You should look particularly of this area, the epigastric area, for visible pulsation, and you can even ask the patient to stop breathing to note that ectonephis. As we see here, there is visible pulsation على راحتك. Okay. Usually a restricted area at the epigastrium will show this visible pulsation. This is considered as a normal finding, but if a larger area is seen here or in any part, really in the epigastric area, one should consider the right ventricular hypertrophy, the pulsatility of the liver due to tricuspid regurgitation, or abdominal aortic aneurysm. If we suppose that I have large area of pulsation, I'll perform this test. I'll put finger side by side and I'll see the pulsation. Really, you have to put your finger parallel to each other and at the outer most area of noticeable pulsation, and look at your finger. If they are separated apart, this means true pulsatility, while if they ascend up and down, this means false pulsatility, thus to say transmitted pulsation. What's the difference between these two terms? Really, true pulsation meaning, for example, if we have an aortic aneurysm, the aortic aneurysm itself will be pulsatile. So if we put our fingers on the outermost sides of this aneurysm, we will see our finger to be pulsatile and separated apart. Transmitted pulsation means that there is a mass over the aorta which causes it to ascend and descend. If the examiner or the candidate put his finger here, he will see his finger just ascend and descend and do not separate it apart. This is about the visible pulsation. So we have to look at the pattern of movement. We have to look at other movement which are visible peristalsis and visible pulsation. Other abnormality should be noted if the abdomen had no movement at all. This is what we call it the silent abdomen and suggest peritonitis. Okay, all of these clinical suggestions and the clinical finding are related to the first step in the inspection, which is the movement, pattern of movement. The second step in the inspection of the abdomen is the contour of the abdomen. Let's look again at the abdomen. As we see here, the abdomen is smoothly convex from above downward and from side to side, with an umbilicus that is situated at roughly mid-equidistance between xivisternum and symphysis pubis. The umbilicus is inverted and has the same color of the surrounding skin color. What are the abnormalities that can be obtained during our clinical training? Really, first of all, if the abdomen had a scaphoid contour, or in a patient who is severely emaciated, we will see that his abdomen is retracted scaphoid. This occurs in advanced case of starvation and in case of malignancy. One should suspect that. On the contrary, if a patient had distension in his abdomen, we have to put in our mind that the distension in the abdomen should be classified into two patterns. The first one, which has symmetrical distension all over the abdomen, and the second pattern when the abdomen is asymmetrically distended. If the abdomen is asymmetrically distended, for example, if the distension just here and here we have normal contour of the abdomen, one should suspect that there is a mass here or visceromegaly, for example, spleen. If we have distension here, one should suspect, for example, hepatomegaly or a mass here, and so on. So as a general rule, in any asymmetric distension, one should suspect mass or visceromegaly. If the patient had generalized abdominal distension, which is symmetrical, one should suspect one of the following causes. Presence of fat, that's to say patient is obese, this is one. Second, if there is feces, if the feces is embedded in the colon, this will cause distension of the abdomen, this is two. Second, if the patient had flatus, gastric dilatation and bowel dilatation or distension due to presence of gas. So we have fat, flatus, feces. Other, in women, we may suggest the presence of fetus and fibroid. Really, other than these differential diagnosis, lastly we have fluid, presence of a fluid inside the abdomen, that's to say presence of ascites in the abdomen. These are collectively, we call them the 7F, which include fat, feces, fluid, flatus, functional, fibroid, and fetus. All these should be put in our mind. This is with respect to the contour of the abdomen. Let's talk briefly about the umbilicus. The umbilicus, as I said, mid-equidistance between xiphisternum and symphysis pubis, inverted, had the same color. If the umbilicus is displaced downwards with the ascites being, with the abdomen being distended, one should suspect the presence of ascites. If the umbilicus is displaced upward, one should suspect the presence of fetus, pregnancy, that's to say, or ovarian tumor, which push, or both of them, push the umbilicus upward. Other abnormality, the umbilicus in case of ascites will be flat, that's to say transversely placed, or even everted. Okay, other abnormality that may involve the umbilicus is when the umbilicus had bluish discoloration. Bluish discoloration, we call it the umbilical black eye or colon sign, which indicate the presence of, for example, acute hemorrhagic pancreatitis, retroperitoneal hemorrhage, for example. Other abnormality that may, or we have to differentiate between the presence of fat and the presence of a fluid inside the abdomen via the umbilicus. The umbilicus, as I said, in case of ascites, the umbilicus will be transverse placed, that's to say flat or even everted, while in the presence of fat, that's to say obesity, the umbilicus will be sunken more than this pattern, or more than the normal pattern. Okay, the third step in the inspection is the texture of the abdomen. The texture of the abdomen, we have to look at the following points. First of all, we have to look at the spider telangiectasia. Spider telangiectasia should be seen at the upper chest, not the abdomen, at the upper chest, just above the nipple. Spider telangiectasia or spider angioma, spider nevi, consists of central vessel which may or may not slightly elevate the skin, from which multiple branching vessel will originate. It follows the rule of 2. It has a diameter of 1 to 2 millimeter up to 1 to 2 centimeter. It's normally present 1 to 2 in number, while more than this number may suggest liver disease. It's really a good sign for a chronic liver disease. If we have spider angioma, spider telangiectasia, and we are not so sure about its presence, for example, if we have here spider telangiectasia, please just press the central arteriole just like this. You will see all the branching vessel will disappear because they are originated from it. So this test will prove the presence of spider angioma. Other is the presence of tattoo in the abdomen. Any tattoo may be therapeutic, and it may be for cosmetic region in the abdomen. It is important because it could be a source of hepatitis B or C if inadequately sterile needles are used. Other, in female, we should look at the linea nigra, which indicate the presence of a pregnancy, and abdominal distension. Other abnormality that should be looked for is the presence of striae. Presence of striae, really look at striae at the flanks area here and here. Striae are strips or lines with irregular borders that indicate either presence of ascites, presence of pregnancy, or recent weight gain, or may suggest Cushing's syndrome, especially if they are white and purple in color. Really, other than this, we have to look at the presence of a scar. Please look at this side. First of all, here, what we call it Mercedes-Benz sign for liver transplantation. Here, for renal transplantation. Here, look at the median scar, upper median and lower median. Here is the para-median scar. Here is the left-right subcostal or cochar. Here is the left subcostal, and here for phalangeal scar, and here for appendicectomy scar. This is about the scar. Look again also for the presence of stoma here. We may note stoma here, or we may have stoma here. Okay, other than this clinical finding, we have to look at any superficial veins, prominent superficial veins. Normally, we may note prominent superficial veins 1 to 2 at the epigastric area, 1 to 2, which is a normal finding. Other than these two vessels, one should look at the site of their presence. Really, normally, the superficial veins surrounding the umbilicus had flow in the following manner: from the umbilicus downward for the vessels which are located below the umbilicus, and from the umbilicus upward the vessel has a direction away from the umbilicus. But normally we haven't the ability to see them. If we have multiple vessels surrounding the umbilicus, just like this manner, and we ascertain for their direction of flow of blood from the umbilicus away from the umbilicus in all direction, this suggests caput medosa and the presence of portal hypertension. If we have a vessel here below the umbilicus and we ascertain the flow of blood to be from downward into the umbilicus, this suggests inferior vena cava obstruction. While if we have vessels here in this area above the umbilicus with a flow of blood that is from above up to the umbilicus, this suggests superior vena cava obstruction. Okay, how can we ascertain the presence of the direction of blood? Let's suppose that we have a vessel here, for example. I'll apply 2 fingers, just like this manner. I'll empty the vessel with 1, and the occluding finger will remain in its place, and then I'll remove the emptying finger and see the flow. If the vessel is refilled, so the flow in this direction from the umbilicus upward, because the vessel is refilled in this way. But if I put my finger and then emptying the vessels, and when I remove the emptying finger, the vessels is not refilled, so the direction of flow must be from above downward, that's to say toward the umbilicus. This is the way of how to ascertain the flow of blood. Other than this abnormality, we have to look at the, as I said, at the umbilicus. For discoloration, we call it Colin sign, and at both flank area for discoloration. If we have a bluish discoloration here, we call it a gray Turner sign, which also suggests the presence of retroperitoneal hemorrhage or hemorrhagic pancreatitis. Other than this, look at the distribution of hair. In male, the normal hair distribution extending from the chest up to the umbilicus and from downwards from the pubic area into the umbilicus. In female, it is usually in lesser degree. There must be no hair in the chest, and if there is any hair extending from the pubic area into the umbilicus, this must be in a slight manner, unlike this clinical setting. Really, all these findings are related to the inspection of the abdomen, and I shall now explain the next step of examination, which is the palpation.